Hello friends, in this lecture I will discuss about drug-coated balloon in the peripheral vascular disease, especially long superficial femoral artery occlusion. I am Dr. Tarun Madan. I am working as an associate professor in cardiology at Institute of Cardiology, UNMICRC Institute, and we'll discuss about what is drug-coated balloon. We have seen that conventional semi-compliant balloon angioplasties are done with plain balloon, which are now coated with the help of an anti-proliferative drug which is released into the vessel wall during the inflation of the balloon, and this drug, when it gets impregnated inside the intima and media, prevents the restenosis. Inflation is done usually at the nominal pressure with specific minimal inflation time which ranges from 1.5 to 2 minutes. Active substance on this DEB or DCB is a lipophilic with high absorption rate through vessel wall. It compensates for a short period of contact between the inflated balloon and the vessel wall. What are the limitations of drug-eluted stents or bare metal stents? Because it leads to vascular inflammation, hypersensitivity to metal, polymer, leading to acute stent thrombosis, and late luminal loss and restenosis, unequal drug distribution, late occurrence of neoatherosclerosis and stent thrombosis, and hampering the future peripheral bypass options, and long-term requirement of DAPT. So drug-coated balloons, they are fast, homogeneous transfer of anti-proliferative drug into the vessel wall during a single balloon inflation time by the means of lipophilic matrix. What are the components of drug-coated balloon? The diagram shows that excipient is coated, which is a urea molecule and which contains active drug, which is lipophilic. And when this balloon is inflated, this drug is released into the vessel wall from inside. Neointimal hyperplasia and restenosis are because of the plain old balloon angioplasty, which is called POBA, but its effect is not durable because of the restenosis. Neo means new, hyperplasia means accumulation of cells, which is a very major side effect of plain balloon angioplasty or bare metal angioplasty. So drug-coated balloons were introduced to perfuse the drug into the vessel wall to prevent or slow the restenosis response. The commonest drug which we use is paclitaxel, though some companies are producing sirolimus or sirolimus drug also. In peripheral vascular disease, DCB therapy has been proven superior to plain balloon angioplasty for treatment of de novo femoropopliteal lesions and some promising results in the in-stent restenosis. Paclitaxel, being an anti-chemotherapeutic drug, prevents the migration of microtubules during the proliferation stage of a cell and prevents the cell proliferation. The Taxol, which is a semi-synthetic form of the paclitaxel, we see that inhibits the migration of microtubules during the cell stage and hence prevents the tumor growth. So vascular restenosis is also a proliferative disease. So in American guidelines also, drug-coated balloon has been devised to manage the peripheral vascular disease. There are different companies which are coming with different devices, but in Indian setup, we use a drug-coated balloon from the company called Medtronic and Boston. So Boston has a balloon which we call Ranger, and Medtronic has a balloon called Impact. It has paclitaxel, which is 2 microgram per square millimeter, and balanced hydrophilic hydrophobic excipient enhances the drug retention and transfer. This was a trial in which Ranger SFA trial was carried out in 105 patients. It showed a very good response in comparison to sirolimus, because sirolimus is a cytostatic drug and paclitaxel is a cytotoxic drug. The tissue absorption is fast and tissue retention is long for paclitaxel. Sirolimus coated balloons challenges are enhanced tissue absorption and extended tissue retention. Sirolimus must be continuously delivered over time, so some form of time release mechanism must be employed to maintain the therapeutic levels. Current scenario, the surgical bypass is still gold standard, but endovascular innovations like DCB, DES, endografts are fast developing. Endovascular treatment advantages are shorter hospital stay, less wound infection, lower perioperative and postoperative mortality compared with open surgery, but late clinical failures like restenosis, target lesion revascularization, TLR, neointernal hyperplasia, and stent fracture still are a major problem. POBA is the first line of treatment, primary stenting in the longer lesion, balloon angioplasty for shortened lesions. and secondary stenting if the patient comes back with a residual stenosis. So DCB also has a similar rationale and technology, same drug concentration, but it is having a longer inflation time. What are the features? Exceptional outcomes, effortless deliverability, efficient drug transfer, and many randomized controlled trials showing favorable results versus POBA up to 2 years. Secondary stent implantation was found to be in 1/5 of patients, around 20%, in comparison to plain balloon, which was around 35%. World's first DCB head-to-head prospective trial, which used Ranger, it demonstrated a similar primary patency with half of total drug dose at the end of 1 year and 2 years. Compare clinical trial of Ranger impact. So the p-value was also significant, and the deliverability is very excellent. It has got a tapered tip. Lutonix is again a drug-coated balloon from Bard. Ranger, Lutonix, and Impact. Impact uses a free pack coating, paclitaxel plus urea, but Lutonix, IFU, get to the lesion within 30 seconds and to not lose the drug during the transport. Loading tool has got a introducer so that you don't rub the drug with the hub of the sheath. And when you bring this device out, you pass it through the introducer. Practical tips: you have to prepare the vessel, pre-dilate it nicely, shorten the transfer time from the access sheath to the DEB inflation, ensure adequate 1:1 sizing between the vessel and the DEB. Single prolonged inflation for complete drug release till the manufacturer's recommended time, which is generally around 1 to 1.5 minutes to 2 minutes. If it is not tolerated, then you have to deflate it quickly. Thank you so much.